Hi everyone. I wanted to give you some highlights of how your role might change with diabetes care once you become an NP. Most nurses are very familiar with diabetes and the types of diabetes and the pathophysiology of diabetes, but your role with these patients is going to change as you go into primary care, and you are going to be focusing on managing and helping these patients to manage their disease. And so the slides are going to take that kind of an emphasis. We're going to talk about how to effectively manage patients with diabetes mellitus and what the standards for that care are. Throughout the document, there will be references to standards of care, and they will come from the Standards of Medical Care in Diabetes from the American Diabetes Association, which are the standards that almost everyone references. And there are a new version in 2008, and I will have the reference for those for you as well. All right, let's talk about type 1 and type 2 and who you're going to be seeing in a primary care practice. Many type 1 patients will be managed by endocrinologists. Not all of them, and it depends on where you are as to how that's managed. If you're in a more rural area, then the family practice may be managing type 1 patients. Children should always be managed by a pediatric endocrinologist if there's one available to them. They have a long time to live with their disease, and careful management is important for them. Also, helping children and families to adjust to this diagnosis and managing them well with their pediatric considerations and their pediatric frequent illnesses is a challenging thing, and a pediatric endocrinologist can really do it best. However, you will be seeing children with type 1 diabetes for some of their routine care, so you need to know what the basics of care are for people with type 1 diabetes so you can ask the appropriate questions. That's why you need to know the basics of managing these patients, even if you're not seeing them. The bulk of the patients you'll see in primary care and in family practice will be type 2 diabetics, which are often managed in these settings. They can be well managed, but you do need to establish some resources outside your practice in order to do a good job. And the two types of people you need to work with carefully are, first of all, nutritionists in your area, and then find out who the diabetic educators are, where the diabetic education programs are that are available to these patients, because you're going to need to be referring them to those educators, unless you're fortunate enough to be in a big practice where they have their own diabetic educator, but most primary care practices don't. So how do you diagnose diabetes? The American Diabetes Association recommends that your best diagnostic tool is your fasting plasma glucose. It's recommended for diagnosing diabetes mellitus. In type 1 patients, there's often little question. Their blood glucose rises rapidly when their disease begins, and so their initial blood glucose is often greater than 300 milligrams per deciliter. You see this in children who come in usually with very high blood glucose levels and often very symptomatic from their disease in a relatively short period of time. There's little question about what they have and really no other testing that is indicated. In type 2 patients, diagnosis may not be so often because the onset is obvious, because the onset is so gradual many times. An oral glucose tolerance test can be used, but the ADA feels that plasma glucose is just a good predictor. Hemoglobin A1C should not be used to diagnose because there aren't any good studies that really show that it is a good diagnostic tool. It is a very good management tool, but not really a good diagnostic tool. Many people who would be diagnosed with diabetes will have a hemoglobin A1C that perhaps is at 7 or below, therefore not a good diagnostic tool. So here's your criteria for the diagnosis of diabetes. A fasting plasma glucose of greater than 126 milligrams per deciliter. This follows an 8-hour fast. Symptoms of diabetes and a casual plasma glucose of greater than 200 milligrams per deciliter is also considered diagnostic. So this patient comes in telling you that they have excessive thirst, excessive hunger, so on and so forth. A 2-hour glucose of greater than 200 milligrams per deciliter during a 75-gram glucose tolerance test. So Any of these would suffice for a diagnosis of diabetes. It goes on the chart. Once it goes on the chart, you're implementing the standards of care of the American Diabetes Association for this patient. This is a big deal for the patient because you're telling them that they have diabetes. They don't have prediabetes, which a lot of patients like to say they have, but this means they have diabetes. How do you diagnose the prediabetic conditions? Usually they're called impaired fasting glucose or impaired glucose tolerance, one or the other, depending on which test used to diagnose. Impaired fasting glucose means their fasting plasma glucose hasn't reached that 126 number yet, but is running between 100 and 125. Impaired glucose tolerance, their 2-hour plasma glucose during the test was in the 140 to 199 range. So these are people at great risk for the development of diabetes and for soon being diagnosed with diabetes. So who do you test? Well, we often run plasma glucose screening routinely on many people, but certainly you want to be sure to test overweight or obese patients who have risk factors such as physical inactivity, a first-degree relative with diabetes, member of an ethnic group with high incidence of diabetes, women who deliver babies greater than 9 pounds, a patient with hypertension, hyperlipidemia, a woman who has PCOS, a patient with cardiovascular disease, anybody over 45 years of age who's overweight. And don't forget to consider adolescents with these risk factors as well as adults, because we're seeing more and more patients who are adolescents who are developing type 2 diabetes. All right, with type 1 patients, how do they present? Their presentation is usually acute. Screening is usually not an issue as symptoms appear shortly after hyperglycemia starts. They have markedly elevated blood glucose. The only good predictors of type 1 are autoantibodies. Since you remember the pathophysiology of this is that these patients develop autoantibodies which ultimately will knock out the beta cells in the pancreas. And once they're gone, they're usually completely devoid of insulin. The autoantibodies appear prior to the onset of symptoms. This has been shown in identical twins, studies of them where one twin develops diabetes. They'll start testing the other one. They'll see the presence of autoantibodies prior to the development of diabetes. The problem is there's no easy, reliable test for autoantibodies. Also, there's nothing you can do about it when they're there. We currently have no therapy that would stop the progression of those to diabetes. Of course, if a patient has a high blood sugar, be alert for signs of DKA. You want to be sure and check them for ketones. So you want to be sure to check for that in their urine, because ketoacidosis can get them rapidly into physiologic difficulty. So really it is the diagnosis of ketone bodies that sometimes helps you make the decision about whether this patient needs to be hospitalized for management or whether you can manage them on an outpatient basis, getting them started on rapid reduction of their blood sugar and sending them off to the endocrinologist. Patients who are ketotic should, in most cases, be hospitalized to get their blood glucose under control. Prevention. Persons with pre-diabetic conditions or risk factors should be appropriately counseled about lifestyle changes, especially weight loss. And you should follow up with people who have risk factors at regular intervals and use regular counseling to reinforce lifestyle issues. This is prevention for people with type 2 primarily, so you can consider Metformin therapy in those classified as pre-diabetic. Your type 1 diabetics, there isn't very much you can do in terms of prevention. And once this process of the destruction of beta cells begins, there isn't really a lot of therapy that's available to prevent it. So we're talking here about type 2 diabetics. So reduction of risk factors and control of weight is very important. If they're pre-diabetic, you can consider metformin therapy. Certainly in women with PCOS, metformin therapy has been shown to be very helpful for them. So here's some of the components of comprehensive diabetic care. These are things that you would want to be sure were included at your first diagnostic visit with the patient or the first time you see the patient, but also many of these elements would be included in regular follow-ups when you are seeing the patient afterward. So if you're seeing the patient for the first time, you want all that history information there, which would include everything they know about diabetes and about their history with the disease, if that's available. If it's a new patient, then you certainly want the family history for sure to know how common this is in their family and what they know about diabetes currently. Your physical exam should include all of these things, and most of these will be included in your regular follow-up visits to the patient as well. Labs, you're going to be doing an hemoglobin A1C at least twice a year, annual lipids, LFTs, urine microalbumin, serum creatinine, and TSH is particularly in women, and referral for an annual eye exam, referral to the dietitian as needed for diabetic education, and to the dentist. So we'll go into all of these in a little more detail. Your management plan should be individualized after discussion with the patient. This is based on your ADA recommendations with an emphasis on self-management for the patient. Again, we're talking primarily here about type 2 diabetes. You need to get the patient to understand that self-management is a very important part of dealing with diabetes, no matter which type you have. And they need to understand that part of that is their diabetic education and establishing a partnership with you in managing their disease. And to make it clear to them that you're not there to tell them so much what to do, but to help them understand what they need to do for themselves. This is really the key to being successful with patients with diabetes. As long as they see you as the bad guy and they're supposed to comply with what you see, oftentimes you're not going to be terribly successful with them. And I can think of numerous patients who kind of took that as their modus operandi, and every time I saw them, they would be telling me how they hadn't really been compliant with their diet, but they saw me as the manager and they saw themselves as the patient still, instead of seeing us as partners. So once you can convince them of that and they can really see themselves in that role, you're going to have much more success with the patient. So what's involved with self-management? Self-management means they self-monitor their blood glucose. For those taking insulin, this means at least 3 times a day. It can be done sometimes less often for those on oral therapies, but even those on oral therapy should be doing it at least some of the time in order to manage their own disease well. I usually start off telling patients that they should be doing this at least twice a day if they are on oral medications, and then you can kind of cut back depending on how you see them managing their disease. Adequate education is a must for these patients, and they have to establish a record-keeping system. What that record-keeping system is going to be kind of depends on a couple of things. First of all, what kind of capillary blood glucose monitoring system are they using? Because some of them have long-term record-keeping systems in them. So I've had patients who come in and they hand me their blood glucose monitor, and I start scrolling back through it to see what their levels have been over the last couple of weeks, for example. However, if they keep a paper record, it's often easier to scan if they're willing to do that, but that involves an extra step for them. As long as they have some record, I think that's the more important thing, and that you are able to review that record. Nutrition therapy. They need intensive education. We'll talk a little bit more about the types of nutrition therapy available to them, with lots of reinforcement, because good nutrition therapy is at the base of controlling diabetes. And they need an activity program rolled into this. That can vary from a simple walking program to something more intensive, because you're going to adjust their therapy based on their activity program, or they're going to adjust their therapy based on their activity program. Your management goals. You want their A1C less than 7%. Their preprandial capillary glucose should be 70 to 130, and their peak postprandial glucose should be less than 180. How closely you approximate this depends upon the patient's characteristics. Now, your A1C is going to be your primary indicator. You have to understand that you exchange reduction of diabetic complications for increased risk of hypoglycemia as the goals are reduced. For example, if you've got a patient with a lot of complications, you may be thinking that they'd do better at something in the 6 range for their hemoglobin A1C, but you have to realize that with that you run an increased risk of hypoglycemia, and whether you're willing to do that may depend on the patient. For example, with children, generally pediatric endocrinologists tend to be a little more liberal with children about their management goals, because oftentimes children tend to be pretty labile with their blood sugars, and their activity pattern tends to vary a lot. They have a lot of intercurrent minor illnesses that will often influence this. And also some pediatric endocrinologists feel that if your control is too tight with kids, they will rebel against that, particularly as they get to be adolescents, and that you're better off to manage them with a little freer hand and keep them within a good range. Also, you have an article on management of older adults. Sometimes having them get hypoglycemic can really have some serious results, and so sometimes you want to liberalize your goals for those patients. So you have to keep that balance in mind with patients. Here's your approximate correlation of your A1C to your mean plasma glucose. So when you look at that hemoglobin A1C, you have an idea of what the mean plasma glucose has been. This means preprandial, postprandial. And you see that 7% gets you at 170. So you would like the mean plasma glucose to be below this when at all possible. So how are you going to treat the patient? Well, your glucose lowering is going to be done with some sort of medication that you're going to use. For type 1 patients, just so you have an idea of how this is usually done, intensive insulin therapy, usually 3 or more injections per day, or an insulin pump, have been shown in the DCCT, which is the big long-term study of outcomes and complications for diabetic patients. It's been shown to improve outcomes and to reduce complications in patients, so that this is what we're aiming for type 1 patients. So this means generally a combination of short, intermediate, and long-acting insulins. So the common protocols that you see, the classic one is NPH or another intermediate BID with coverage at meals with regular or ultra-rapid acting insulin. However, you can also use the basal insulin, the glargine insulin, often given twice a day with mealtime coverage, as you would with NPH. And this is being done more and more often. This is particularly helpful with patients who tend to be fairly brittle, because the basal insulin is likely to have less lability of blood sugar associated with it. And so more and more people are experimenting with that for the management of type 1 patients. If you're thinking about how to prescribe this, your total daily insulin requirements are often calculated starting at 0.6 units per kilogram of body weight, figuring about half of that for your intermediate or basal insulin and the remainder for your meal coverage. This is just a starting point, and after that you adjust it based on the patient's blood glucose records. So they come into you with their record of their blood glucose testing, and you're going to look at that and you're going to adjust it up or down depending on the carbohydrate load at the meal. So obviously, if dinner is the heavy meal, you're going to give more coverage to the dinner time than you are to breakfast and lunch. But you also have to think about the fact that you're usually going to have some snacks in between so that your patient doesn't get hypoglycemic. This is where the nutritionist is helpful to you. They'll set up a carbohydrate load for the patient at the various meals. This helps you in knowing how to prescribe their insulin. Your long-acting insulin can be prescribed your 50% of your daily dose, but then how you divide it morning and afternoon will also be dependent on the patient's activity and meal pattern. For type 2 diabetes, the recommendation, if the blood sugar is not too high or if they're pre-diabetic, is often metformin with lifestyle changes first. See how successful you are. Again, you're doing the same sorts of things you're doing with patients with trying to get them to reduce their lipids. You have to find out how willing they are to make those lifestyle changes and to talk to them about the importance of those changes. But you can certainly try metformin. Starting out with metformin BID for the patient, often 500 milligrams to start with, upping it, again depending on their blood sugars at the time that you're starting this, and then sending them off for a nutrition consult and some diabetic education, and then following them closely to see what you need to add. Then you add other agents as needed, including insulin, if indicated, to keep in target. Currently approved diabetes medications. Okay, there was to be a link on this slide, and I will post the slides with the link in it. I can't show it to you, but it comes off of one of the NIH websites, currently approved diabetes medications, so that you can see all of the medications that are currently approved. Often after you start with metformin, you go to a sulfonylurea to add as your second step. Your most common insulin regime these days is adding glargine insulin at bedtime to the oral meds. So if you've used metformin and you've used your sulfonylureas, then and your patient's still not meeting the targets, you can add glargine insulin at bedtime. But there are other medications available to patients now that can be particularly helpful sometimes before you go to glargine insulin, and I would suggest you look at that list first. There are lots of different regimes for medications that you can add that can help patients to reach their goal. But glargine insulin is a good choice. And patients sometimes are a little resistant to insulin, but sometimes just 10 units at bedtime can make all the difference in the world. Medical nutrition therapies balance exercise, diet, and medication. And this will, of course, be what you want to do. So the nutritionist is going to talk to the patient about their exercise regime and going to base their carbohydrate management on that. You want to bring the patient to a normal weight range. The diet should be controlled for fat and carbohydrates, for calories, and should be high in fiber. Commonly recommended diets. The two commonly recommended choices for patients are carbohydrate counting and the ADA exchanges. They each have their advantages and disadvantages. Carb counting is easy. All you have to worry about are the carbs, and they're usually done in units of 15 grams of carbohydrate, and the nutritionist will set it up so that they get so many carbohydrate units at each meal and show them how to figure that out from the nutrition labels. So if you're looking to find some sources on that, there's lots of them up on the web. I've put one up here on carbohydrate counting, which gives you the basics of carbohydrate counting. It's much easier than trying to manage the patient with exchanges, because all they have to worry about their carbs. They don't have to worry about the proteins and the fats as well. What are the disadvantages of carbohydrate counting? The disadvantages are that you tend to have possibly a less well-balanced diet. So you have to talk to patients when they're doing carb counting about being sure that they are controlling their fat intake, and getting adequate protein is usually not a problem for Americans. They usually eat more than adequate amounts of protein. So it's really controlling fat that is more of an issue. The ADA exchanges probably most people are familiar with, and this would include looking at your exchanges for fats, proteins, and carbohydrates, and having the nutritionist then set those up for the patient with so many exchanges per meal time. It's more complicated for the patient, but their diet is likely to be more well balanced with ADA exchanges. more and more people are going to carb counting because it doesn't overwhelm the patient and seems a little simpler to them. Less commonly used, but interesting these days, is a vegan diet that was originally introduced by Neil Barnard of the Physicians for Responsible Medicine, and it's gained quite a following. And he has at least one major study that shows some great success with the vegan diet. So at first glance it looks difficult. Here's the website for it, but this really is about his book, but you can also get some information on the diet itself from the website, so I suggest you go and have a look at it. It looks difficult at first because a vegan diet is obviously not easy because you have to give up so many different kinds of foods. However, the patients who like it say that it's sometimes easier to give up whole food groups and to know that you just can't eat certain things than it is to have to count everything that goes in your mouth. And I can certainly understand that. These patients actually eat a lot of carbs, but they do well on this diet and they manage to keep their blood sugars under control. So you might want to have a look at it. Not as widely accepted these days, but he gives talks around the country on the use of this diet, and if you look at it on the web, you'll find some interesting testimonials, plus his study with a follow-up on the patients who used the vegan diet with great success. So it's something interesting to kind of keep an eye on. Now, what's called DSME, Diabetic Self-Management Education. Patients need intensive education at diagnosis and may need it at other times. I've certainly had diabetic patients come back and say to me, I think I need to go to class again because I just need to get back on track and I need to remember all the things that are important in managing my disease. And that's a wonderful thing to do, to have a patient ask you to go back and get some more education. Most places that do diabetic education will do it in group classes, but then sometimes can follow it up with individual sessions with the diabetic educator. So you need to locate those resources in your community. They're often at a hospital that has a diabetic education center. Self-management is the key to successful outcomes, and you have to understand the disease to be able to do that. Besides educating the patient, there's often a lot of support provided by diabetic self-management classes because the patients meet other patients with the disease, and they often establish relationships with those patients, and they talk to each other and support each other as well. There's considerable evidence amassed to confirm the necessity of education and its success, and it is covered by most third-party payers because they know that this will result in management of the disease. Now, how do you follow up with diabetic patients? And what kind of screening do you do? Well, cardiovascular disease is a major complication of diabetes, so all these patients should be screened regularly for hypertension and hyperlipidemia. Since the goals of therapy for hyperlipidemia will be low for patients with diabetes, at least less than 100 LDL, often these patients will end up on lipid-lowering drugs, so many of your diabetic patients will require this. Routine aspirin therapy is also recommended for all diabetic patients. Kidney disease is a major threat for diabetic patients, so your best prevention here is optimal glucose control, shown again and again in studies of glucose control. You want to check urine microalbumin at least annually. This can be done in the office, and measure serum creatinine at least annually. You want to use ACEs or ARBs for patients with hypertension or those who have microalbuminuria. This means a spot check for microalbuminuria that exceeds 30 micrograms per milligram. And again, this is easy to do in the office. Retinopathy screening is essential. Your best prevention for retinopathy is, again, optimal blood glucose control and blood pressure control. They need a dilated exam by an ophthalmologist annually. Refer immediately if the patient reports to you any vision problem or you detect any macular edema. Laser coagulation therapy can reduce vision loss in these patients, so catching any vision changes early can mean that they then can have laser coagulation therapy and preserve some of their vision. Neuropathy screening should be a regular part of your visits. You educate patients about foot care. You screen for foot and lower extremity problems. You check pinprick vibration perception and monofilament pressure sensation for distal polyneuropathy every time you see these patients. That means every 3 months when they come in, you have to educate your staff, shoes and socks off, because this is going to be a regular part of the visit. And you do autonomic neuropathy screening by history taking. So these patients can not only have distal polyneuropathy, they can have autonomic neuropathy, which will often show up as orthostatic hypotension, constipation, or erectile dysfunction, very common in diabetic patients. What kind of follow-up should you be doing? Stable patients at least every 3 months. Patients not achieving targets more frequently as needed. The elements to be incorporated include a history and physical exam that will screen for all complications. Patient education as needed and adjustment of therapies based on the visit and the labs that you are seeing. So you may be seeing patients very intensively every couple of weeks if they're not meeting targets, and depending on how far off they are from those targets. Those stable patients, you set up a routine visit every 3 months. You need to set up a system to track your patients so that they aren't lost to follow-up. And this means that you've got some system in your chart, for example, some kind of a little record that indicates easily on one of your flow sheets when they last had their annual testing done, when they last had their vision screening, when they last had their microalbumin tested, so on and so forth, so that you don't miss those annual screenings and that you aren't having to look back through your notes to see when that was done last. Also, in terms of follow-up visits, if a patient cancels, you need to have some kind of a record-keeping system that will alert you to this so that you can reschedule that appointment, that patients don't go long periods without being followed up. All of the standards in the slides have come from the ADA standards, which are available in a PDF in Diabetes Care, and they are part of the unit. And then a good article that I just found that I will post in the unit is an article on starting insulin therapy in patients, which I think may be very, very helpful to you.